Dr Alastair Santhouse, Al, as I'm now going to call you. Thank you so much for joining the Hurt Healing podcast today. I'm incredibly excited to have this conversation after reading your wonderful book. And yeah, go from there.
Thank you. It's a pleasure to be here.
So you open the book by discussing what we might consider to be normal mental health, which I think is such a sort of slippery, loose concept. What actually inspired you to write about it, and why does it matter so much for how we think about mental illness?
I think that's a really fundamental question. And what really inspired me to write it was an observation of in clinics, but in wider society too, about the number of people who identify with having a mental health problem. I think there was a study a few years ago of students where 78% said that they had some kind of mental health difficulty. And in my clinics, people come forward thinking that they might have a diagnosis that perhaps a generation ago they really wouldn't have thought about. And I felt it needed understanding and explaining. I know what you mean, though, about the concept of normal and where the boundaries of that lie and how you can define it, if you can define it. Do you define it by the absence of normality, by saying that someone's got a mental health problem or mental illness? Is that how you do it? But I felt that this was something that needed to be thought about and discussed. And really that was the starting point for the book.
I think, as you say, I think normal is such a loose term, and I actually did an interview a few weeks ago, and we were saying maybe it's actually more helpful for someone to say they're not ordinary, rather than having this concept rather than having a concept of normal, because my normal isn't necessarily what your normal is, and my idea of what's weird might be your idea of what normal is.
I mean, there's something in that, but I would say that broadly there is a whole range, a way of being. And fundamentally, it doesn't really matter in the respect if you can function in your life, if you have, let's say, a social life, a personal life, hobbies and interests, occupation, then your personality, how you relate to the world, isn't really the factor. I would say all those are broadly within the category of what you might want to call normal. I think where you're really unable to function for some reason, where you can't engage in those aspects of your life for whatever reason, that's, I wouldn't say that someone's abnormal, but it crosses a line in which, it might be reasonable to think about getting help, whatever help that looks like. That might not be because you've got a defined mental health problem or mental illness, but there comes a point when if you're not really able to function, that's the point at which I think I would say there's something to be addressed or resolved.
And I think that's what I find frustrating about this age of overdiagnosis that we're living in. And I think obviously I caveat that with the fact that sometimes in some echelons of society there's a massive issue of underdiagnosis. But where there is this issue of overdiagnosis, it's not through people being unable to function. It's this sort of idea of putting a label, and particularly with things like ADHD, we're putting labels on people just because they display certain characteristics or traits of someone who might have ADHD, which is helpful obviously for someone like you who's a psychiatrist in a diagnostic respect. But actually, it's not really helpful, I don't think, for the individual to label themselves as having ADHD.
Right. I mean, I think this is a very fundamental problem that you've addressed, which is it's not a benign thing to put a label on someone. Psychiatric labels, I think, are sticky labels. They tend to stick to that person, and I think it alters their self-perception in a way. And it can create that environment in which there may be an expectation of a certain harm or way of being, and it might create that climate in which they think that they're not really any longer in control. It removes a certain agency. You say to someone, you've got this diagnosis and now you need help to be able to navigate that diagnosis. So I think you remove something from someone. So although it might seem kind in some respects to acknowledge people's suffering in some way with a diagnostic label, I think that for many people it isn't that. And you remove something from them. I think it creates potentially a climate in society where these things are common. The more that they're heard about, the more people relate to them, and there's a certain kind of looping effect. So I think we need to be careful about diagnostic labels. And that was, again, you talk about what led to write the book, but that was a fundamental aspect too, which is what are we doing? What's it saying about us as a society? Is it moving in the right direction? I think there's often a conceit that society always moves in a linear direction towards something better than went before. And sometimes you just need to take a beat and say, is this leading us in the right direction? And that was, again, a fundamental question that I wanted to ask.
And I think as someone who was diagnosed very, very young with anorexia and OCD, I have carried those labels. And as you said, it's sort of pigeonholed me in certain ways. And I now don't really know whether to say to people, I have anorexia, because although I don't sort of appear to have anorexia, I still definitely have an eating disorder. And so I always pause sometimes when people say to me, oh, well, why did you start the podcast? And I just said, well, I have OCD because my OCD is still very active and alive in me. But then I sort of pause and I think, I struggle with an eating disorder and I had anorexia, because I don't think I'm necessarily anorexic anymore, but I definitely have traits of it. And I think it is helpful for psychiatrists like yourself to be able to put people in certain brackets, because obviously it helps with treatment. However, there's so much overlap and crossover. And now I'm increasingly talking to people who are not only diagnosed with OCD, but then it's ADHD, it's also autism, it's also an eating disorder, it's also a drug addiction. It's sort of, well, where do you stop? And I do take issue with the 12 steps sometimes, where you introduce yourself as, I'm Pandora, I'm a drug addict, or I'm Pandora, I'm an alcoholic, because again, you're sort of personifying the illness in a way, and it's you're absorbing it as part of your own identity.
Well, I think identity labels are an interesting one. I mean, I think with the addictions, I think sometimes their sort of notion is that you're never entirely free of it and you need to be constantly vigilant. But I think for the sort of labels that we're talking about, when I started in psychiatry, I think stigma was a big part of why people didn't get help or were never treated for things now that perhaps they would come forward for. So I think the sort of reduction in stigma was something that needed to happen and was well due. And I think everyone would be behind that. But we always used to say to people back then, you're more than just a label. You're a person with this diagnosis. And yet somehow over time, as the number of diagnoses that people have has escalated, people sort of define themselves a little bit. You might see an X or Twitter profile, and the first thing people tell you about themselves in a 5-word sort of précis of who they are is what their diagnosis is. And I find that a strange one to sort of reconcile, which isn't that what the whole anti-stigma campaign was about? And so the diagnostic labels, I wonder about, and I think it reinforces the fact that some diagnostic labels haven't lost their stigma, because people are far less likely to tell you about schizophrenia or psychosis or other things that they have. So again, it's a cultural moment that we've arrived at, where this sort of thing is in, people talk so publicly, but not just have a diagnosis, but want to display that diagnosis.
And also there's so much misunderstanding that still surrounds conditions, particularly like schizophrenia, OCD, for example. You know, every other person self-diagnoses with OCD. And in fact, as someone who has really been completely paralyzed by OCD at times, OCD is very different from what the general public think OCD is. And I think that, you know, again, it's so problematic to simplify these conditions it seems to be a bit of a reductionist approach that a lot of people are taking now.
Well, I mean, it's something that I think about a lot. I mean, again, I'm all for reduction in stigma, and I'm all for diagnoses being talked about in the way that we are now. But in terms of reductionist approach, I mean, I think there is maybe a popular concept that diagnosis is just an easy thing to do. That if someone tells you they're depressed or they check things a little bit, that they must have depression or OCD. Whereas actually making a diagnosis is a pretty strenuous kind of mental task of hypothesis testing, of interrogation of these various hypotheses, of trying to put together someone's symptoms in the wider context of their life, their social circumstances, their experiences. And I think that, or my worry is that in the public mind, to some extent, people think, well, you just need to have a few of these things and that qualifies you for the diagnosis without really contextualizing it. And that's something that I think can be a problem. For example, the way depression is diagnosed now compared with a few generations ago, I think it would look very different and people would think very differently about it. Perhaps we'll come to that later.
Yeah, no, absolutely. And I think, again, this is the issue with things like autism and ADHD. It seems that the scope is really widening for what actually does constitute autism or ADHD. And as you allude to in your book, the DSM, which is the Diagnostic Statistical
Manual.
But yeah, I always so it's like, but again, the scope for diagnosis has widened so much, which is something that you take issue with as well. Because I totally agree. If you're sad, it doesn't mean you're depressed. Just because I go back and check if the door's locked, it doesn't mean I have OCD. And actually, again, I was doing some research for a guest who has very bad OCD, and she was saying that when the NHS handed her a checklist for what constituted OCD, she didn't actually tick any of the boxes because her OCD was all covert, ruminative, magical thinking. And therefore, she wasn't eligible for treatment because she didn't actually, in their eyes, have OCD. So it's if things are getting missed, but then things are being overdiagnosed. So is that something that you grapple with?
I do. I mean, it's interesting you mentioned that. A friend of mine called up NHS 111 with a headache, and the operator went through a list of other potential symptoms, one of which was neck pain. And she'd said that she'd slept badly the night before, but on that algorithm, headache and neck pain meant meningitis, and the person insisted on calling an ambulance for her. Even though she was trying to say, no, that wasn't it, and she was just answering the questions as they were asked. But I think that's an issue with a kind of a checklist approach, is that it lacks wisdom, and it lacks the context, and it lacks all of those other things. And I think that's why it's important, if you're making a diagnosis, that it's, as I said, a sort of a time-consuming and fairly intensive kind of task.
Yeah, and so why do you think that the rates of people being diagnosed with ADHD and autism are going up? Is it because of this widening in criteria of diagnosis, or is it genuinely because we're feeding our minds with material that is, not really enhancing that side of our brain and therefore making people develop things like ADHD and autism more?
Well, it's a big question that you've asked, and I think there's a number of aspects to the reply because it's never just one thing. I mean, I think certainly the diagnostic criteria, one paper said, just failed to differentiate essentially between normal, well, broadly, we struggle with this term normal, but for the sake of the discussion, between pathological mental states and normal mental states. In other words, the symptoms are often quite common and relatable, like not wanting or being able to complete tasks that are boring, or cutting across people in conversations, or being impatient and just not taking your turn, and there's obviously a question of degree, but in a milder degree, these things are quite common and relatable, and people may say, that's me, I'm always losing things. So I think part of it is the diagnostic criteria are quite broad. I think, secondly, there is a sense in which the more a diagnosis is talked about, the more people begin to wonder if it applies to them. This is what we call the looping effect, where people hear about it, there's awareness raising, it must be a common thing, and then people understandably wonder if that could be them. And I think as well, I'm not someone that has a big issue with pharmaceutical companies, but I would just say that it aligns with pharmaceutical company goals, which is that the number of prescriptions has increased enormously for medications to treat ADHD in this case. So there's a whole sort of confluence of factors operating at an individual, a societal level, maybe outside factors as well, that all lead in the same direction towards this expansion in diagnoses. one of the biggest rises I've seen in my professional life is adult ADHD, which we really didn't talk about a generation or so ago, except as childhood ADHD that hadn't attenuated over time. Whereas now, arising for the first time in adulthood, there was one paper that looked back at whether people in childhood had, whether these adults had just got missed childhood diagnoses, and they found that in 90% there was very little evidence of any childhood neurodevelopmental disorder. Now, I'm not saying that these adults weren't suffering with something, but it's very hard to make a case for a neurodevelopmental disorder if there's no neurodevelopmental problem that people can find. So I think there's, as I said, just a range of factors now that seem to be leading us in that direction.
Okay, so Ali, when I hear that, I think, well, is it not then to do with the fact our attention spans are just getting smaller and smaller due to things like social media and instant gratification and, platforms like TikTok, where our attention span is encouraged to be reduced to, say, 3 seconds, as opposed to 30, 40 years ago, where it was normal to read a whole article in a newspaper, which now is just not really the norm. So is it the case that actually we're feeding our minds things which are encouraging us to develop ADHD? And would it be that actually if you were to do this in 50 years' time, you'd find that the adult onset of later ADHD isn't actually as prevalent because the sort of technology and things hasn't changed as much as it has in the last 30 years?
I mean, I like the theory. I think a lot of the people with adult onset symptoms that look like ADHD often have a variety of other things. Depression, it may be a personality type, it may be anxiety disorder, it may be something else that might be diagnosable or might be, again, coming back to this word, broadly part of normality, the spectrum of normal human behaviour. But to your question, if you go back to the 1800s, Beard, he was an American neurologist, and he talked then about fatigue states, what he called neurasthenia, being caused by the pace of modern life. He said, telegraphic communications of steam engines and of periodicals and all those things. I think there was medical historian Skull who talks very well about that. And I think throughout the last 100 years, people have constantly worried about this kind of thing. Our attention span, was it polluting us? The introduction of television and all of those things. So, I wonder if this is just another one of those steps on the road and that this isn't fundamentally that different at all. You might be right, though. Maybe there is something in it. And I'm not sure I know my own mind on that. I'm just saying that we've sort of been here before over the last 100 or so years with people wondering about whether there's something now about modern life that's causing the illness. It could be, but I'm not yet persuaded.
So you don't think that the rise of social media is contributing towards this surge in ADHD? You would say that it was more to do with a widening of the diagnostic criteria?
Well, I guess the short answer is I don't know, but I'm not quite seeing the evidence, and so I'm not sure. But I think that there's other explanations too. Possibly it's a factor. The evidence for whether watching TikTok videos means when you're back in the workplace you now can't complete a task or you won't do. I'm not sure if that link sticks. It's it's a hypothesis, and I think we need to take it seriously. And I know a lot of people do. A lot of people would say that is an issue, but they often talk about it in terms of depression or anxiety disorders. I don't know if the evidence yet supports it.
Interesting. A lot of people find it confusing what the difference between a psychiatrist and a psychologist is. Would you mind clarifying the difference, and then we'll go into what your role actually involves in terms of making diagnoses?
So, well, psychiatrists have been to medical school and have gone through medical training, qualified as doctors. And in my case, I also did my postgraduate physician exams and then psychiatrist exams. So that was my route to where I am. Psychologists have usually been through a different type of training, often as normal human behaviour. It might be the It might be mental health, or it could be occupational psychology, or it could be a variety of others. In fact, I think there's sort of, there's dozens of different sorts of therapeutic techniques, approaches to existential psychology and all sorts of others, as well as the CBT that people know, and the ACT and mindfulness. So there's lots of different approaches. The psychologists I work with would probably broadly work in the same model of diagnosis as I do. But I think when people talk about diagnosis, they often talk about it in terms of just a medical biological diagnosis. I think when I'm making a diagnosis, I would look at not just the biological, but also the context of someone's life, their habitual thinking patterns, their social life, their background, upbringing, occupation, relationships. In other words, the diagnosis is always set in this biopsychosocial kind of model, and a lot of the psychologists that I would work with would probably work within that same model, but just have a different aspect in their role in patient care.
So as far as I'm aware, the psychologist delivers the therapy more, whereas the psychiatrist is responsible for sort of overseeing it and the diagnosis, and for also being able to prescribe medication if that's needed.
Yeah, that's a fair characterization.
And so as a psychiatrist who takes issue with the DSM and the way it operates, how do you really, what really informs your ability to diagnose, and how do you look at a patient when I come to you and I say, okay, Dr. Santhouse, I think I have really bad OCD and I think actually I might have autism, which has never been diagnosed. Where would you start with someone like me?
Well, I think it always starts in taking the history and the onset of the problem that you've come with, the nature and degree of it. By the way, DSM and ICD, the International Classification of Diseases, are not always bad. It's just I don't think they're always adhered to. And so I think the starting point would be to try and get some sense of it. In other words, if you said, I've got OCD because I check the door after I've left the house, that's one thing, or I check it twice. But if you're saying I'm going back 6 or 7 times, I get to the tube and then I come back and then I have to take a photo to reassure myself that I've done it, that's starting to have far more real world effects on you, your sense of well-being, your ability to engage in normal day-to-day life. And I've seen people with OCD that really can't leave the house till noon because the ritual of getting dressed can be so prolonged that it has to be done in a precise way, in a precise order, and any deviation of that means they have to start all over again. And I think it's hard to mistake those. I think anyone would say, yes, that represents a real problem. You talked before about someone where it was a largely mental experience of ruminations, of magical thinking. And then again, it depends the extent to which it's really interfering with their life, occupying their waking hours, unable to remove that thought from their mind. So I think you get a sense of the nature and degree, the context of someone's life. And if you're, and then if the question is, and I also think I've got autism, then you have to go back to the beginning with that as well and say about your childhood, about interactions, friendships, reciprocity, sharing, and all sorts of other factors right through to now, and how it might affect you. So that might be quite a long consultation.
So it all rests essentially on how much does it interfere with your quality of life?
I think to an extent, the diagnosis doesn't always define itself by that. These things are operationalized. So if you have these 4 out of 6 symptoms, then you might qualify for the diagnosis, that sort of thing. But I think the extent to which you would want to intervene or offer medications or that sort of thing, I think that's a discussion that you have with the individual about the extent to which it really is impacting on their life. And some people, it can be quite paralyzing.
Yeah, and then you get someone like Elon Musk, for example, who's achieved incredible things, and yet he himself admits he has no social life. He's an awful father. He's, his ability to hold down relationships is severely compromised. And so, there can be superpowers as part of these diagnoses, right? You can have OCD or autism or ADHD, and you can have that ability to hyperfocus. And often I think people with these mental health issues do have these incredible superpowers. And I remember once someone turning to me and saying, but reframe your OCD, because in some ways it's your superpower. And it was the first time I sat back, and it was only last year, and I thought, you know what, actually, you're right, because having seen it as such a, as such a negative imposition in my life, and as such a sort of negative part of myself, and something that was such a source of shame, I suddenly thought, actually, try and reframe it. And as per our earlier conversation about pain, it's actually sometimes reframing these things. And instead of feeling like a social pariah or an outsider because you've had a label put on you, sometimes it's turning it around and realizing that actually our brains work in such a unique way. And wow, I've got this ability to have this sort of focus on certain things, and okay, it can be to my detriment, but if I manage to shift that and channel it into something that's positive and not self-destructive, it can be immense.
It's an interesting way you framed it, because I've often wondered what it means to have a superpower. Because most people would say, if someone says my OCD is my superpower, I'd want to understand what that means. Because usually people think of it as a detriment. But I think what you're saying is that you unlock different ways of navigating the world, of managing things, a certain resourcefulness or a difference that is of benefit to you, that fundamentally is a different sort of aspect of you that you might not have unlocked before. And I can get that.
Yeah, and don't get me wrong, like, oh my God, it's paralyzed me throughout my life for long periods of time. But I think components of it is really what I'm saying, not as sort of general as a sort of general illness to have. Of course, it's horrible, but actually sometimes looking at the bits that you can pick out that might actually be a positive.
Yeah, I can go along with that. It's just that when it's presented as, a great thing, and I'm not saying that's what you've done, but I think that can sort of feed into other people saying, well, actually, I wouldn't mind some of that. And
no, completely. No. That was definitely not the point I was attempting to make.
No, I did get your point, though.
Would you mind going into autism? Because again, I think this is a condition that isn't really understood by that many people. Yeah. Is autism something you're born with, or is it something you can develop over time?
Autism is a neurodevelopmental disorder that you're born with. So, and there's, I don't think it was formally classified till about 1980. It was initially thought of as a form of childhood schizophrenia. So people weren't exactly sure how to relate to it. Once autism was first sort of talked about in the 1980s classifications, the sort of forerunners of DSM-5 or ICD-11 we're up to now, it was quite a rare disease, or illness. I'm not, disease is the wrong term, but it was quite a rare condition. And it was, I remember there's a textbook or a handbook that I used. It was 1995, I think, and it said the rate was 2 in 10,000 was the rate, and the said about 15% of people would be able to live independently, and about half people would have normal speech. So the original sort of framing of autism was a pretty severe illness that became apparent, relatively early on in infancy. There was also a separate diagnosis called Asperger's, which was people who were generally higher functioning, but who often couldn't really engage in social reciprocity. They couldn't really read other people, relate to emotions very well, often had quite sort of samey kind of hobbies like collecting old football programs in a slightly obsessive way. And although they could navigate the world, it was that sort of emotional and social kind of relationship that they struggled with. And I think many of us knew people like that to some degree, and often at university you'd meet people like that. Recently, those categories have been merged. So, and it's sort of what led to this autism spectrum disorder now. And I think so part of what we've called autism is actually an amalgamation of different categories. But then again, I think the number of people identifying with that has increased. And often I've struggled to see where the forerunners are, or the deficits in social interaction, or all the other things that usually go with that diagnosis. Because ultimately there is a spectrum of ways of being, and at what point we call it autism is a question that increasingly is taxing people.
Yeah, and I was very definitively told that I did not have autism because I didn't struggle with social interactions and I had friends. And I don't know, I go in waves of thinking, gosh, no, but I display so many characteristics of ASD. I'm very particular about how I have my food on my plate. I get quite distressed if something's missing. I do things in a very particular order. I don't like people in my personal space very much. But then, and so it then goes back to our earlier point of, is this all a sort of continuum? And actually, is it where we're placed on that continuum?
I think so. And also, I mean, I'm not here to make any spot diagnoses, but that sort of particular way of doing things also is a
very OCD trait, right?
Yes.
Yeah, exactly. So
there is, you can see already that there is an overlap. And then the question is, what is the benefit of making a separate second diagnosis when the first one might explain it better anyway? So I think, and that's why I'm saying that it's often a sort of a difficult task. You need to relate to all of these ways of being, interactions and preferences. And yes, there is a range of human behavior.
Yeah, no, and that's why I sometimes do take issue with all these late diagnoses when someone's had a primary diagnosis of something like OCD, then they're sort of subsequently given a diagnosis with ADHD and autism and an eating disorder and an addiction. It's like, well, how does that necessarily help us if we've got to a place where we're managing our lives? Of course, if your life has become unmanageable and you're in search of different types of therapy and new treatments, then it can be immensely helpful. But I do sometimes struggle to understand how psychiatrists think it's helpful putting so many different labels on one individual.
Yeah, I think I'm of the same view, that it's better to have one thing that explains most things than 5 different labels that each explain a little bit. I mean, that's what Occam's razor was, which is looking for that most parsimonious explanation, and I'm right behind you there. I think sometimes people do accumulate labels and they go to different people who will see a different aspect of them, and I think that's why it's so important to try and at least start this conversation of the sort that you're having now about how is that helpful, and can we sort of undiagnosing people, it's an ugly word, I'm not even sure it is a word, but it's a hard thing to do, and so I think we need to be careful about when we apply labels.
No, I completely agree. At what point do you decide to prescribe someone with medication? Because I think, again, this is an issue we're facing today, is that so many medications are overprescribed and people are going to their GPs and they're saying they feel slightly down and they're immediately given a prescription for citalopram or sertraline or an SSRI, and then we find we've got a nation of people who are addicted to these antidepressants. And I've spoken to so many people who are trying to titrate off these medications, including myself, and it is the most horrible process.
Well, I mean, I think that's a very fundamental question that gets to the heart of a lot of stuff that I'm talking about. I mean, I said earlier on we might come back to something, for example, depression. And I think if you go back to the 1970s, depression was a pretty rare illness, treated by specialists in usually a hospital kind of setting. And we fast forward to now, where depression is a common illness treated by generalists in primary care. And of course, I don't blame anyone, because I know GPs are working under a lot of pressure and they see a lot of people, but often the medications are easily available, more so than a course of therapy. and it can be tempting. I think the second thing is there's often not time to engage with that discussion. If there was one paper written by someone called Kendall, which I liked, it looked back at the description of people with depression back then. I think it was going about 100 years back. I'm not exactly sure, but the description was so much richer, sort of broken-hearted, or heartbroken, in agony, all these sorts of very colourful kind of descriptions of people. Whereas now it's often a checkbox, sort of not sleeping, sad, not concentrating well. There's a few things, but it lacks that sort of real engagement with the individual. And I think it's easy to score above threshold on a lot of these charts. So to come back to your question, at what point I might prescribe, again, I think there's a discussion to be had about whether, the extent to which this is a depressive illness versus some other thing that needs an entirely different sort of treatment approach or pathway, or, in other words, for example, loneliness, I think is a real social problem in the whole of our society, and maybe unemployment or housing insecurity or financial instability, or all of these things where people look at the future, feel bleak, alone, abandoned, sad, uncertain of who they are, what they stand for. All these things that could look like depression, and I'm sure on a score sheet would qualify for that. But actually, it isn't that. And what you need to be doing is to looking at other aspects of their lives, so of maybe some kind of social prescribing or social engagement or something else entirely. So I think it always comes back to this first thing about making the diagnosis, which isn't easy. If you do make the diagnosis of depression, I have lots of conversations with people, and some people just don't want to be on antidepressants, and I can understand that. And I don't push the case unless I really think that their mood isn't going to improve without it. But there's other ways of managing it too. But I think the bigger picture in this country is that I think there's a British Medical Journal paper that showed the number of antidepressants has, I think this must have been about 2020, but it was about over 70 million, with a year-on-year rise of antidepressant treatments. And I think it had doubled in not that many years. In other words, there is a question to be resolved about the use of those medications, about how we're thinking about that, and are we using them as they should be used. So yeah, I mean, it's a complicated story.
It is. And although I'm all for destigmatizing them, because I remember 15 years ago when I was at university, I mean, it was a real source of shame being on SSRIs and antidepressants. And I remember saying to a few of my friends, very sort of secretly, I do take antidepressants, but I was very much in a minority. Mm-hmm. And now it's just like people are sort of broadcasting it from the rooftops. It's like a rite of passage, yeah, I'm on antidepressants too. Yeah, me too. It's become a sort of almost like
Yeah, it has. And there is, from where I've come from, my sort of emergence into the medical world was in the early 1990s. And so, and there was a Royal College of Psychiatrists campaign, I think 95, 96, called Defeat Depression, which is, just to your point, which is it wasn't anything shameful or to be embarrassed about. And I think I never thought we would be successful in that. But as it turns out, I think we, at least for certain mental illnesses, we have been. I suppose your point is, have we gone too far in it? Is there such a thing as too far? I don't know. Again, that was part of why I wrote this book, is to try and bring this out into a public conversation, because I think that the risk of a position like mine is that it might be seen as unkind.
Yeah, and I also, obviously I have this podcast, and I'm not one for saying that I don't think people should be diagnosed, and I don't think people should shy away from saying that they have X, Y, and Z. I mean, here I am, a kind of a living example of that. I think it's absolutely crucial. And for me, it was a huge part of my journey sort of to start healing really from what I had and dispelling the shame and the judgment. But I just take issue with this fact that sort of every single person seems to now really have a mental health issue.
Well, I mean, the question is have we as a profession, psychiatry, done a good enough job of, differentiating normal from abnormal? And again, we've discussed what difficult concepts they are, but that's a question to have. Is it helpful? Does it lead to some of the public being skeptical about the diagnoses? If they hear that lots of people have a diagnosis and they say, well, I've seen them and they don't seem so bad. And I think there's a question about who gets care, who should access care, and we always live in a world of limited budgets. What's happening there? We know there was, I think an Economist article said there was about a rise of 1 million people on mental health waiting lists in the past 5 years. And the question is, how are we going to manage that? For all the time, a lot of diagnoses have been increasing. Some of them haven't. The rates of schizophrenia will have remained pretty stable. Will they be getting less of the budget? Should we be advocating for a bigger budget? What do we do about the inability of people to work because of mental health problems? I mean, that's something that was exercised in the government. And I'm not especially political about these things, but only to point out that they have real world consequences that need to be thought through.
I mean, that's something you highlight in your book as well, the number of people now who are not working due to poor mental health, which has gone up exponentially in the last 10 years. I mean, to the point where it's actually quite shocking. I mean, I can't remember the exact statistic, but I think it's 10% or something?
I can't remember the number, but I think for the age group under 44, it's the commonest reason now why people can't work. And again, it's not that I'm unsympathetic to this, but we need to understand and explain and try and address it if we can.
Yeah, and you do not want to be met with, I worked at a law firm in my 20s, and it was I was taken very seriously because I was not in the majority. Whereas I was having a conversation the other day with a partner at a law firm, and he just said, I mean, it now takes up 5 to 9 hours of my week due to administrative sort of stuff around to these trainees who are all alleging to have mental health issues. And it then gets to the point where you're met with an eye roll if you say that you have a mental health issue.
Well, that's what I was referring to, and I think that's something that I've observed too, which is that people say that they've got a particular issue, and people are perhaps a bit more sceptical now, and this is what it comes back to, which is who's it helping, and is this a good thing, and have we gone too far? And where is that public conversation? And the problem with the public conversations is that the framing of them always seems to be, well, you're trying to take something away from us and it's unkind of you to deny us something. So I've found it can be difficult to have a conversation of the sort we're having now because you're almost put into a role of saying, well, you're not really very compassionate. And I struggle with that. I don't like to think of myself in that, as not being compassionate, but I do think we need to be able to talk about it.
Yeah, and I think there needs to be a massive rebalancing, because the problem is that, like you said, with the waiting list, it really detracts resources away from those who actually really desperately need them. I mean, I think the average wait time now to get an appointment for ADHD is something like 9 years on the NHS.
There was a BBC article, I think it was 8, but that's not massively better.
Yeah.
And probably some of it's now being outsourced to private firms. And again, there may be issues with the quality. I don't know who oversees the quality control. Maybe they're very good, but I think that we've clearly, it's escalated to the point where the NHS isn't really coping with that.
And do you think there's a chance that psychiatrists are ever going to become more discerning about their diagnosis, or do you think it's just going to be a slippery slope towards more and more and more?
Well, I mean, sometimes there's a strange inversion sometimes I've noticed in a consultation. If you go to a doctor and you're worried about having a problem, the doctor says, well, actually, I'm happy to tell you don't. You think, oh, thank goodness, it's great. But I've had the opposite with that in consultations, sometimes about ADHD, where I've said, look, I really don't think this is a realistic diagnosis, and people are often a bit upset or even offended to be told that. And it's, perhaps they've joined a sort of ADHD support group, and it's part of their identity now, and they don't. And it's unusual because we always assume that it's a good news conversation for someone to be told they don't have something, but that isn't always the case anymore.
It's an interesting point you make that, because as I alluded to earlier about the anorexia, I find it really hard now, sort of almost disentangling myself from that identity as being an anorexic. Because now people who maybe just met me, didn't know me when I was sort of in the grips of it, would be, but you don't look like you have anorexia, which again is just completely misinformed, because you can have anorexia and not look like you have anorexia, but that's by the by. I don't really identify with having anorexia anymore. And for, I think, part of my healing, there was a period when I had to grieve that, definitely. It was saying goodbye to that chapter, saying goodbye to the person that was always depleted, the person that never ate sort of X, Y, and Z, the person that was always going to show up and bring her Tupperware of food, and always being the skinniest in a room of people by and large. And now, I'm so relieved when I see someone who has anorexia, which I find very sad now. It actually, it does take me back there, but there's not a part of me that wants to go back there. But it is equally hard when someone says to me, but you don't have anorexia. So it's a funny, as you said, it's a funny quandary to be sort of confronted with. But I mean, as you said, if you go to a doctor and you think you've got a broken leg, and they do a scan and you're told you don't have a broken leg, oh my God, the relief. It's like, oh my God,
Absolutely.
great.
And I sort of make the point about that in, for example, something like trauma, which is another sort of category of diagnosis that often is a very sort of broad and increasingly self-defined concept. If you, as I gave the example, if you fall off a wall and you've had a traumatic leg injury, and the doctor says to you, don't worry, it'll get better soon, I think you'd just feel relieved. But I think if you said, I fell off a wall and I was traumatized, it was really scary, and the doctor says, I heard what you said, but don't worry, you'll feel fine soon, you might feel that doctor wasn't really paying attention, he wasn't really sympathetic, didn't take it seriously. I think there is a different relationship people have with their sort of, the way they relate to their mental health now. And they might not be reassured by things that we might have thought would be reassuring. And, the language of mental health is everywhere. I go on Twitter, and I go on, I used to go on TikTok, I've deleted it now. But, 5 signs that your ex is a narcissist, or 3 signs that your boss is a psychopath. And all of these things sort of lead you to think that, or have you been traumatized? If you've got any of the following, then you must have been traumatized. And I don't blame the public, it's a very broad term, isn't it? But I don't blame anyone for thinking that they might do if that's what they're exposed to and that's what they see. And I've often lamented the fact that psychiatry just doesn't seem to be in that conversation. There's no one, at least I'm not aware of really anyone sort of advocating on behalf of psychiatry on Twitter or other places and saying, no, this is what we mean. Well, there might be a few, but they don't seem to have as big a voice. Maybe it's the sort of thing we say is maybe a bit more dull. It's not, it's, if you stand at Hyde Park Corner and you say, be nice to your mother and, exercise and eat vegetables, you're not going to have a big group of people gathering round looking like it's a great insight. And I wonder if psychiatry is sort of talking about more nuanced, difficult concepts that you can't easily explain, whether people just don't easily engage with that.
Yeah, well, it's a problem. It's this sort of, it's this culture of clickbaity hooks, isn't it? And it doesn't really sound that appealing if you said, oh, well, you might be suffering from some kind of, I don't know, sadness as a result of the fall, as opposed to you've been traumatized by the fall. It
Yes.
just I hear school children in the streets around here saying, "Oh my God, you're going to have PTSD after that lesson today." I mean, and as you said, it's like, God, my mum's such a narcissist, and I fell into that trap for a number of years, and now I really have to check myself, and I now use the term narcissist as I say clinically diagnosable narcissist or narcissistic behavior, because there's a big difference. And I think we're so flippant with these terms, like trauma, like narcissist. By default it becomes a part of your vocabulary, doesn't it?
It becomes part of the vocabulary. It becomes part of a public conversation, and it sort of loses connection with actually what it was meant to be. There was, often personality disorder is essentially used as a term for people you don't like, and that can't be a good thing. There's sort of more pejorative, X is a narcissist, or words to that effect. It's never a good thing for them, and so that but it's become so much part of the public conversation that it can be hard to row it back and say, no, this has a pretty precise clinical meaning, and that's not what we mean by it.
Yeah, when I was young, I remember it. It was a psycho. You would call someone that you didn't like, or someone who you thought was really weird, a psycho, whereas now it seems to be a narcissist. It seems to move in trends.
Things always move in trends, but psycho is presumably from psychopathic.
Yeah.
I assume that was part of where it came from.
Exactly. So to finish, Ali, do you think we are facing... Al, sorry. To finish, Al, are we facing a mental health crisis in your view?
Well, that's a really good question, and I think it depends what you mean by crisis. If you mean, is there something about our modern world that is generating more anxiety, more depression? I think I don't doubt that during COVID, people often did struggle mentally. I think life is really difficult for people, and I don't underestimate that. I talked before about all the adversities, the real world suffering that people go through, the loneliness and the financial insecurities and all of that. And so I think that there is something about our society of an increased level of suffering that that could have validity. The question is whether these things would qualify for a mental illness, which is really what we mean by mental health problem. At least I assume it's what we mean.
We do. Yeah.
That case, I think, is a bit harder to make in my view. And so I suppose I think, yes, I don't want to underestimate or downplay the real world suffering. That's not what I'm saying. But do we have a crisis of diagnosed mental illness, or ones that I think would be valid diagnosed illnesses? I think I'm less sure about that. And I think, as I said earlier, there's a lot of factors that have led to a place of increased diagnosis, not all of which relate to having that mental illness.
Well, lots of food for thought, and I think lots of people will find this episode absolutely fascinating, as I have. So thank you so much for joining us today and for your time, because it's been really enlightening, and I urge everyone to buy a copy of your brilliant book, and we'll put the link in the show notes. So thank you very much.
Thank you. It was a great pleasure to join you.
Thank you.